So the whole focus of outcome-based commissioning is that it will reward providers for improving wellness, improving the care pathway and improving recovery across all care settings for a particular patient population. There really isn't a blueprint for outcome-based commissioning. I know we'd all like to think there was, but there isn't. It is really an experiment. And for the NHS, it's a very new experiment. The theory of outcome-based commissioning is still pretty elusive, and the translation of the conceptual into the granular is also pretty difficult for us to get right. So what we've been doing is looking internationally to see whether we can learn lessons from those who've actually done it, who've gone on that journey. And despite the fact that the NHS is somewhat unique, there are lessons internationally that we can draw from to help us build something that's really practical and workable. Some of those lessons cover how outcomes are measured. Some cover how pricing and reimbursements are implemented in a practical way. And some cover, and perhaps most importantly, will cover the engagement of patients, carers and their families, because that's at the heart of what we're trying to achieve. But for me, one of the most important things to appreciate and the lessons to be learned from the international experience is that change doesn't happen straight away. If you implement one of these contracts, you really can't expect the benefits to be realised immediately or even within a year or two. It's a journey of change that the purchaser and the provider have to go along together. And one of the key issues is the readiness of the provider to take on this new role of managing a care pathway across the whole supply chain. So in the USA, they've developed some tools for providers who want to take this role on to use to assess their readiness to take that journey. And these tools are actually used by purchasers as well to assess whether the providers are ready. And the tools cover things like leadership and culture, the existence of clinical protocols, operational protocols, business intelligence, analytics and so on. Actually all the things you would probably expect you'd need in some kind of accountable care type contract arrangement. The big thing for me though, and the one which I think is the really genuine barrier for the NHS, relates to health information and electronic health records, and in particular health information exchange between health and social care professionals and patients and carers as the patient travels along that journey. This isn't just about business intelligence, this isn't about just reporting metrics. This is about a carer or a clinician sitting with the information that they need that's relevant to the decisions that they're currently taking about the patient's care, and embedding that information within a clear clinical protocol and operational protocol to manage the patient population. We are a long way away from that in the NHS. There are very few examples of healthcare systems which have really got that in place, and almost none which involve social care. So for me, this is the biggest barrier, and it's the journey that's going to take slightly longer than one might reasonably wish it to. Is it worth going on this journey? It's quite a transformation that we're trying to achieve, and it sounds terribly complex to somebody who's used to the existing NHS and delivering care within that. I think it is worth taking. It's a big prize, and I like to put myself in the position of a patient and how complicated the system feels for them at the moment, and how inefficient it is, and how they can see the inefficiencies and the sort of parallel universes that the various care settings and healthcare professionals have to operate in because of the way that we currently work the system. So for me, this is really about demystifying it for the patient. And if that means it's a bit more complicated for the system to operate it, well, as I say, the prize is big.